Hello and welcome to Badger Talks Quick Picks, which bring exciting happenings, resources, and talent from your UW flagship campus to the people of Wisconsin and beyond. I'm Mia Williams from Chicago, Illinois. I'm a recent graduate of UW-Madison's dual degree MPH-MPA program through the School of Medicine and Public Health and the Follette School of Public Affairs, studying health policy and education policy. I'm pleased to introduce Christine Durrance, who will discuss the Follette School of Public Affairs Main Street agenda, touch on why some Wisconsinites are concerned about healthcare, and then cover one important aspect of healthcare in Wisconsin, the ongoing opioid crisis. Professor Durrance studies health economics and health policy, focusing on maternal, infant, and reproductive health, risky behavior, including substance use, the opioid crisis, violence and child maltreatment, and competition in healthcare markets. Much of her work focuses on vulnerable populations and utilizes secondary data and robust econometric methods to identify causal effects with important policy implications. Please welcome Christine Durrance.
Thank you so much for that introduction, Mia. I'm excited to be here today and to talk to you about health and healthcare in Wisconsin with a particular focus on the ongoing opioid crisis. So today, we're going to talk a little bit about the Main Street agenda and what it has to say about health and healthcare in Wisconsin. We're also going to talk about the opioid crisis nationally and here at home in Wisconsin, and how this crisis has affected a particular vulnerable population of pregnant individuals, mothers, and children, a population that is often overlooked and is the focus of some of my ongoing collaborative work with others here at the University of Wisconsin. So with the upcoming election, the Main Street agenda is a collaboration between the Follette School of Public Affairs and the Milwaukee Journal-Sentinel to share insights about how Wisconsinites feel about policy topics that are relevant to the 2024 upcoming election. As part of this effort, a statewide survey has been fielded asking Wisconsinites about the issues that are most important to them in the upcoming election. As you can see on this slide, we've covered a number of topics so far, including gun violence, climate change, and others. But we've also talked about healthcare and health in the state as well. So Wisconsinites are also concerned about healthcare. Healthcare is the third most pressing issue for those surveyed. About half of Wisconsinites surveyed indicate that healthcare is either quite a problem or an extremely big problem. Almost 70% of Wisconsinites surveyed feel this way also about healthcare nationally. This issue is bipartisan. It reaches individuals across urban and rural communities. It also appears to be a bigger issue for individuals who identify as female and for those with young children. Of course, big changes in reproductive health policy in the US and in Wisconsin in particular with the 2022 Dobbs decision may account for some of the larger focus by females in this survey. So what kinds of things do you think Wisconsinites are worried about when they indicate that healthcare is a major issue? Healthcare is a big focus area. Healthcare issues and health policy issues, needed to address them is constantly evolving and becoming more complex. So what are respondents thinking about? Are they worried about health insurance coverage? Are they worried about the cost of healthcare? Are they worried about out-of-pocket healthcare costs, accessing healthcare themselves, or some other aspect of healthcare policy? Healthcare and health policy is more than just about health insurance and about healthcare costs. The US experienced the COVID-19 public health crisis, and the last election was very focused on COVID and its ramifications when voters thought about healthcare and health policy. The US is also seeing changes in health policy around cannabis, recreational, medical uses of cannabis. Voters are also worried about the prices of prescription drugs and so much more. But what I thought we'd talk a little bit about today is that importantly, the US is still experiencing an ongoing opioid crisis, an issue that affects everyone. Whether you know someone who has used or misused opioids, suffered from an overdose, someone with chronic pain, or if you have children that you worry about experimentation with substances and the risk of potentially deadly opioids in the market. So today we're going to spend some time thinking about one big health policy challenge, the ongoing opioid crisis. So some big questions in this space are thinking about why is the opioid crisis one of the big issues facing the US? Who is affected by the opioid crisis? And what can we do to address this ongoing crisis? So I'm going to give you a little overview about the opioid crisis nationally and here at home, an issue that some voters might be concerned about. So over 1 million people have died from a drug overdose since 1999, and the lion's share of these overdoses are related to opioids. This crisis has affected men and women, individuals across race and ethnicity, and across geography. Deaths are occurring from both prescription opioids as well as illicit opioids like heroin and fentanyl. Although opioid prescribing has fallen and we saw a drop in overdose mortality in 2018, overdose mortality has increased after that and also continued to increase as this crisis collided with the public health crisis. So how did we get here? In the 1990s, there was not a great understanding about the addictive nature of opioids, and there was a large increase in prescribing. If you take a look at the sort of well-known figure that I have represented here, wave one is represented on the left side in the green area, and wave one represents about 1999 to 2009, when there was a large increase in prescribing for opioids. During this time, doctors prescribed a lot. There were some doctors that were employed in pain management clinics or pill mill clinics that were prescribing a lot. And pharmaceutical opioid suppliers were also oversupplying. We move into wave two, which is represented by the blue box at the bottom and represents 2010 to about 2013. And this time period is associated with large increases in heroin mortality. This wave was largely driven by shifts to the illicit market as access to prescription opioids changed, as some recognition of what was going on with the opioid crisis was happening, and led to higher overdose mortality attributed to heroin use. Wave three, which is the wave that we're currently in, starts in 2014 and extends forward and is represented by the purple box at the bottom. And if you follow along the purple line in the figure on top, you'll see a dramatic increase in opioid overdose deaths that are attributable to synthetic opioids, or what you hear a lot about in the news, fentanyl, which is a powerful opioid usually used to treat cancer pain, but has been manufactured and produced illicitly and is now very prevalent in illicit markets. So what we see here in Wisconsin mirrors the trends that I just showed you in the United States. On the left-hand side, what you see are increases in opioid overdose deaths in Wisconsin between 2000 and 2022. And you'll see that in 2022, there were almost 1,500 overdose deaths in Wisconsin attributable to opioids. On the right-hand side, you can note that there is considerable variation in overdose mortality across the state, where darker areas, darker counties are associated with higher rates of opioid overdose. And you'll note in the top that most of these opioid overdoses, at least in the most recent year of 2022, which is what's represented in the graph on the right-hand side, are attributable to synthetic opioids or fentanyl. So what are we doing in the US and in Wisconsin in particular to address some of the opioid crisis? So what we often think about in public health and in economics are strategies that are designed to think about primary or secondary or tertiary prevention. Tertiary is what we often think about as harm reduction. And so in this list of policy actions at the federal or state level, these will fall into different categories of thinking about what kinds of prevention these are really designed to address. So some of the things that we've seen at the federal level and some more at the state level are changes in prescribing guidelines with respect to opioids and education, both for patients, physicians, and pharmacists to understand the risks of opioid use and opioid dependence. We are also seeing changes in access to evidence-based treatment for opioid use disorder. This is often through changes in access to medication that's used to treat opioid use disorder. These are medications like methadone, buprenorphine, and naltrexone. We've also recently seen the removal of data waivers, which prior to the removal had limited the number of providers who could prescribe medication for opioid use disorder and limited the number of patients that each of those providers could serve. We also have seen the adoption, including here in Wisconsin, of prescription drug monitoring programs, which are databases that identify controlled substances that are being prescribed and provide this information to prescribers, physicians, as well as pharmacists, dispensers, to identify patients that may be dependent on opioids, but also to think about the prevention of diversion of those opioids to others outside of that system. We've seen regulations of pain management clinics or pill mill clinics to stop or slow the overprescribing of prescription opioids and possible diversion of those opioids. We've also seen harm reduction strategies like naloxone access laws, Good Samaritan laws. These types of laws are attempting to increase access to naloxone, which is a reversal drug in the event of an opioid overdose. And these types of policies, along with safe injection sites and needle exchange programs, recognize that substance use is happening, but try to minimize negative consequences, including overdose and other harms from opioid use. We are also at a point where we are seeing settlements that are coming from ongoing opioid litigation in light of the responsibility that the opioid manufacturers and distributors and other key players had in this crisis. There are substantial settlements coming out of this litigation, which will provide funds to states to address some of the kinds of policy actions that we talked about here on this slide, but to address others that are indicated by the state. So what I wanted to do is to think about one overlooked aspect of the opioid crisis, and that is the effect of the opioid crisis on women, infants, and children. There are lots of researchers working on many aspects of the opioid crisis here at UW and across the US. Some of the work that I am doing here at UW with my collaborators specifically focuses on the Wisconsin population, the opioid crisis, and this particular vulnerable population. So while the substance use crisis has affected large portions of the American population, we also see big impacts specifically for those who are reproductive age, pregnant, and their infants. Our survey data from Main Street Agenda suggests that voters are showing increased concerns about healthcare by women and parents of small children. These are vulnerable populations who may be underserved, and it's critical that we don't lose sight of them in this crisis. When pregnant individuals use substances during pregnancy, there can be adverse impacts on the infant. One outcome that we're going to talk a little bit about today is a condition called neonatal abstinence syndrome, and this is a withdrawal condition at birth that is usually associated with opioid use while in utero. So you'll notice that this is sometimes abbreviated as NAS at the top of this slide. So between 2010 and 2017, the number of babies that were born with a neonatal abstinence syndrome diagnosis increased by 82% nationally. These infants are expensive to care for, and these infants are usually cared for with government funds, thinking about Medicaid, as most of the infants that are born and given a NAS diagnosis are Medicaid insured at birth. So in my collaborative work with colleagues here at the University of Wisconsin, we are investigating the impact of prenatal exposure for this population. We're able to use unique linked administrative data with partnerships made possible through state agencies and through the Institute for Research on Poverty here at UW to link Medicaid claims with other information on social welfare participation, child protective services records, educational outcomes, and more. In our research, we leveraged the largest sample to date with detailed information on prenatal opioid exposure and other important characteristics among Wisconsin Medicaid covered births. In these data, we are able to identify prenatal opioid exposure by identifying prescription opioids that appear in our Medicaid claims, medications themselves that are used to treat opioid use disorder, as well as proxies for potential illicit opioid exposure using other information that we have in our administrative claims data, all which occur during the prenatal period. So I thought I'd share with you just a small chunk of some of the work that me and my collaborators are working on. So to start, we conducted an exercise to estimate how many births are affected by opioid exposure. We also study to what extent prenatal opioid exposure affects birth outcomes. We also study how prenatal exposure affects health and development in early childhood. And I'm going to allude to some other things that we are working on as well. So using our data, we are able to estimate using a variety of definitions which births are likely affected by some opioid exposure during the prenatal period. We start with infants that receive a NAS diagnosis. This represents about 1.7% of births in the Medicaid population over this time period. We then create a number of different measures, which you can see here on the right-hand side, that indicate different levels in terms of opioid exposure likelihood and in terms of opioid exposure risk. And we cumulatively sum the percentage of births that are exposed to opioids based on these different definitions, both in terms of type and amount of exposure. Our most inclusive definition, which includes any exposure to opioids during pregnancy, even a single opioid fill, indicates that approximately 20% of births in the Medicaid population have some possible opioid exposure. This upper bound varies in terms of the risk of exposure and the likelihood of exposure based on our measure, but indicates that a sizable proportion of births in Wisconsin have at least some opioid exposure. The next step in our research is to understand the ways in which prenatal opioid exposure may affect birth outcomes and also potentially affect later health and development outcomes. We find that prenatal opioid exposure is strongly associated with a neonatal abstinence syndrome diagnosis. And we also find that opioid exposure is associated with worse infant health outcomes using traditional measures like low birth weight, small for gestational age, as well as neonatal intensive care unit admission or NICU admission. We find that these effects are more pronounced for exposure to opioids that are used for the treatment of OUD, opioid use disorder, as well as for possible illicit exposure relative to traditional prescription opioids. Traditional prescription opioids are less related to the infant outcomes that we study in this work. We are also studying the relationship between prenatal opioid exposure and health and development outcomes among young children, and we look at these children as they age until age 5. Our results suggest that significant opioid exposure, which in this study we identify as having chronic exposure to opioids or 90 or more days exposure to opioids, is associated with some increased risk of cognitive and intellectual disability diagnoses by age 5. So this is ongoing work where we are answering many other questions. What I've provided is just a snippet of some of the work that we've done so far. We are also considering the relationships between prenatal opioid exposure and referrals to Child Protective Services. Wisconsin is one of many states that has a prenatal substance use law requiring that in many cases a NAS diagnosis or other evidence of withdrawal at birth triggers a referral to Child Protective Services at birth. We are also studying the relationship between prenatal opioid exposure and later educational outcomes, which is possible using the data that we have available to us at the WADC and at IRP. Importantly, especially in this opioid crisis, is access to opioid use disorder treatment, both in terms of prescribers who are prescribing buprenorphine, as well as opioid treatment programs. And so we are also studying access to opioid use disorder in the state in terms of geography and distance, and so much more. So I thought I'd end by thinking a little bit about why this crisis and why this research is important. I hope I have convinced you that the opioid crisis is an important aspect of health and health policy, and that mothers and children are an important population to study. In our work, we have found that prenatal opioid exposure is prevalent. A large share of Medicaid-covered births are potentially exposed to opioids during the prenatal period, as high as 20%. This 20% captures variation in the likelihood of exposure and the risk to prenatal development. As health policy has been adopted addressing the opioid crisis, we see fewer pregnant individuals exposed to prescription opioids, but we see more pregnant individuals exposed to medication for opioid use disorder and potential illicit exposure as well, implying the greater role of illicit opioid exposure in this more recent phase, this more recent wave of the opioid crisis. This population deserves attention because prenatal opioid exposure not only has consequences at birth, but may have other medium or long-run consequences down the road on later life, health, and development, as well as CPS involvement. We think our work provides insight into concurrent, and intergenerational effects of the opioid crisis, with strong implications for the expected burden on health, welfare, and education systems, and that this implies that treatment and remediation efforts should be concentrated during the prenatal period. I'll stop there. Thank you so much for watching. If anyone's interested in talking further about this important topic, feel free to email me at my email address on the screen.